Chapter 31, Older Adults. So, people with mental illness prior to age 65 usually continue to experience symptoms and continue to need care later in life. In addition, mental health prior to age 65 does not provide older adults with immunity from subsequent psychiatric conditions. Too often, disorders are left untreated. Many older adults do not recognize symptoms. Some deny there is a problem. Others feel shame and concern related to stigma, and others dismiss symptoms as part of getting older. So life expectancy and number of older adults are both growing, which means that there are more older people with high acuity health problems that we need to take care of. Your common classifications: young old is considered 65 to 74, middle old 75 to 84, old 85 to 100, and then your centenarians 100 to 104. Now, mental health and aging, late life mental illness, is less likely to receive the appropriate diagnosis and treatment necessary. Psychiatric conditions such as major depressive disorder, cognitive deficits, and prolonged grieving are not a normal part of aging. Diagnosing and treating psychiatric disorders prolongs the individual's ability to remain independent and increases the ability to take the lead in personal choices. Major depressive disorder. Since it is more common in individuals with chronic health conditions, older adults are at an increased risk. This should not be confused with dementia or delirium. And onset is the telltale sign because delirium occurs suddenly in hours or days, and depression increases and persists for at least 2 weeks, and dementia is slow and progressive over many years and affects memory and daily functioning. Major depressive disorder is quite common after cardiac events and strokes, but care providers can confuse it with dementia or delirium. Depression and the non-agitated form of delirium, which is called hypoactive delirium, may result in the common symptoms of apathy, withdrawal, and tearfulness. Onset is a key assessment finding. While delirium occurs suddenly over a matter of hours or days, depression grows and persists over at least 2 weeks. Dementia results in profound memory disturbances that impact day-to-day functioning with a slow and insidious onset. Now, there is something called a geriatric depression scale, which focuses on mood. And you use this assessment if the patient answers yes to questions such as, are you frequently sad? Because feeling low may be a sign of depression. I thought we had a copy of the scale here. Yes, we don't. Suicide is more common in men over the age of 65 and is equally common in both genders over the age of 85. Now on page 564, table 31.1 gives you suicide rates by age group. Now, early identification of risk factors and treatment for depression are key measures for suicide prevention. Risks for suicide include diagnosable psychiatric illnesses such as psychosis, anxiety, substance use, and previous suicide attempts. Other risks are psychological alterations such as personality and emotional reactivity and impulsiveness, but also stressful life events. Remember that older adults often experience undiagnosed depression and are disproportionately more likely to commit suicide. Anxiety disorders are usually underdiagnosed. Anxiety disorders are usually underdiagnosed and is often related to pain. Fear of falling is also seen in the older population and may result in activity restriction and something called agoraphobia, which is fear of crowds and fear of leaving home. Page 565 gives you a fall efficacy scale. You can also see risk factors on page 565. These risk factors can include anxiety related to childlessness, low socioeconomic status, and having experienced trauma. Other risk factors include being female, single, and having multiple medical conditions. Protective factors include social support, spiritual beliefs, physical activity, cognitive stimulation, and having coping strategies. Now, delirium is secondary to a general medical condition, and it's important to identify the cause and treat the cause accordingly. It may present as disorientation in older adults, and it may be labeled as dementia and it's disregarded. It is crucial to obtain data from family or caregivers about a baseline level of functioning. A patient who is newly confused, falling, disrobing, and fighting with staff should always be assessed for delirium. Ask family members questions such as, has your mother been shopping or cooking for herself? Does she pay her own bills? Or does she ever get lost when driving? These may give subtle clues about whether changes are acute or have been coming on slowly. Treatment of delirium begins with identifying the cause. The delirium may be due to drug reactions or toxicity, infection, electrolyte or metabolic imbalances, anemia, thyroid dysfunction, vitamin deficiency, stroke, and a multitude of other problems. Neurocognitive disorders are the most common is Alzheimer's and vascular disease. Both are characterized by a functional decline, aphasia, which is difficulty finding words, apraxia, which is difficulty carrying out motor functions, agnosia, which is failure to recognize objects, and disturbances in executive functioning. Executive functioning would be things like organizing, planning, abstracting, insight, and judgment. Changes in executive functioning may result in forgetting how to make old family recipes or the inability to pay bills. Tragically, limited insight and judgment often lead to increased vulnerability to exploitation. Now, with Alzheimer's, there are 7 stages that match disease progression, and this is best found in your ATI book. Stage 1, there is no impairment. Stage 7, there is no cure. Or stage 7 is at the height of the disease. Alzheimer's is diagnosed by ruling out other possible causes of dementia, and it is based on DSM-5 criteria. There is no cure for Alzheimer's. It is also best for a patient diagnosed with Alzheimer's to live at home for as long as possible so that they are in their normal surroundings. Alcohol use disorder is the most commonly used substance in those over the age of 65, and it usually involves environmental conditions. That may include retirement, widowhood, and simple loneliness. Now, there are risk factors on page 565 that you can see here. And risk factors for heavy drinking in older adults are being male and being single, having less than a high school education, low income, and cigarette smoking. Additionally, depression often plays a role in increased alcohol consumption in the older adult. The older person who misuses alcohol may be confused, malnourished, unkempt, thin, depressed, and unsteady. Diarrhea, urinary incontinence, decreased functional status, and failure to thrive may also be present. Long-term excessive alcohol use can lead to alcohol-induced dementia. Symptoms include impaired executive functioning and significant lack of insight. This is in contrast to the memory or language problems of Alzheimer's. There is also a Michigan alcoholism screening test, and the geriatric version is a good assessment tool, which you can find on page 566. Pain. Pain is a major factor in daily functioning, performing your ADLs, self-esteem, and emotions. Pain in older adults usually results from arthritis, peripheral vascular disease, and diabetic neuropathy. And we're going to go into more details of this in the next slide. So let's start with barriers to an accurate pain assessment. Older individuals may be hesitant to report pain due to the thought that it is a normal part of aging, or that it is expensive to run certain tests. There may also be language difficulties due to dementia or strokes, but they may also have sensory impairments that can also cause problems during your assessment. Family members, again, can be very helpful regarding normal behavior in any new complaints. Now, there are assessment tools we can use. The Wong-Baker Faces Scale, as you see on page 567, can be used to help older adults understand how to rate their pain versus a numeric scale. But then there's also a pain assessment in advanced dementia scale, and this is used to evaluate those with advanced neurocognitive deficits who are not able to communicate verbally. Pain management. It is important to assess for side effects since the older population tends to take multiple medications. You first have your non-opioids, which is things like acetaminophen, which is your drug of choice. However, non-opioids can cause, like acetaminophen, can cause liver toxicity, and they do not treat inflammation. Next, we have our opioids, which are used to treat moderate to severe pain. Elderly are more likely to experience liver or kidney issues, which puts them at an increased risk for toxicity. Chronic pain should be treated by a pain management specialist, not just by your average doctor. And then non-pharmacological pain treatments. This can include things like physical therapy, exercise, yoga, cold packs, heat, and massage. Now on page 568, I'm going to recommend that you read box 31.3 for tips for pharmacological pain management in older adults. So let's talk about healthcare concerns of older adults. Financial burden, which is huge. Think about retirement, the inability to work, disability income, Social Security income, etc. Healthcare expenses for older adults are nearly 4 times higher than the expenses for the rest of the population. Now, some older adults have to choose between paying their bills, buying groceries, or buying medications. Medicare Part D has helped with medications, but there is still a financial requirement. So learn the needs of the patient and educate them on any resources that are available. Caregiver burden. Chronic illnesses can be difficult to handle as a caregiver due to added emotional, mental, and financial stress. Those with mental disorders usually have even less support as they age due to damaged relationships when they were younger. The support system of those aging with chronic mental illness often becomes case managers, community nurses, and mental health providers. Ageism. Ageism refers to the negative stereotypes, prejudice, and discrimination toward others or oneself based on age. And we can dig into some subcategories here. Language. The term elderly is no longer used because it portrays a picture of being frail and sick. Senior citizen is also no longer used. We now say older adult. Public policy. There are certain organizations that are designed for the older population, such as AARP, and research. Previously, clinical trials for treatment and medications were focused on those under age 65, but now research is including more of the older population. So I want to go back up to just ageism in general and talk about some of the consequences for ageism. So you will actually find some staff who will not work with older patients because they feel like the patient can't offer much to them. Long-term care staffing is often very poor. Older adults are often given less information about their conditions and fewer treatment options. And public policy honestly discriminates against programs for the elderly. So healthcare decision making, advanced directives. These are also called living wills. are legal documents that provide instructions for medical care, and they only go into effect if you cannot communicate your decisions for yourself. You also have portable medical orders, or called POLST. They're portable medical orders that communicate to healthcare facilities and providers the patient's wishes for end-of-life intervention, including emergency services. And then guardianship. This is a court-ordered relationship in which the selected guardian acts on behalf of another individual. For this to happen, the patient or the ward must be proven to lack capacity to manage personal and/or financial affairs. All right, so the nursing process. It is important to assess functional ability and emotional status. These are going to be priority assessments. When you conduct your assessment, provide a private interview space with adequate lighting and low levels of noise. Establish rapport with the patient and convey warmth. Ask them what they would like to be called. Don't just assume. Perform their physical assessment, which is going to be a head to toe. Do a medication reconciliation. Document all medications. Assess for polypharmacy and prescribing cascades, which is when a medication is prescribed to treat a drug-related symptom, because this could help determine if delirium is present. Educate your patients. Educate that they should not take multiple medications with anticholinergic effects due to adverse consequences related to accidents and injuries. Perform a mental status exam. Cognitive, emotional, and behavioral assessments are necessary. Also use screening tools such as that geriatric depression scale and the Cornell scale for depression and dementia are also helpful. And you can find these in box 316 on page 573. Older adult drivers, be mindful that vision changes and cognitive deficits may impair their driving abilities. Older adult abuse, we're going to talk about in more detail in chapter 28. We're not going to dig into that. Just know that you are mandated reporters. Facts and myths about aging. There's a really good box on page 571 that I recommend you read over. Now, your nursing diagnoses, the International Classification for Nursing Practice provides useful nursing diagnoses for older adults. Their diagnosis will focus on safety, higher level needs, caregiver stress, and impaired family processes. Outcomes, share decision making, and come up with realistic goals for your patients. Implementation. So there are psychotherapeutic methods. This is active listening, encourage the expression of feelings, provide health education, assist in problem solving, provide group counseling, and build relationships, but also have psychotherapy involvement. Treatment modalities, there are lots of psychological therapies, but they're provided by advanced practice practitioners. Evaluation, of course, is ongoing, and you may have to revise your plan of care as needed. Now, restraints. Let's talk about restraints in these older adults, and you need to refer back to Module 2. However, remember that restraints cannot be a PRN order. They are not as needed. Restraints are always, always, always the nurse's responsibility. You may delegate putting on the restraint in the patient care, but the nurse is ultimately responsible for the safety outcomes. Remember that restraints are always the last resort, and if you have to place a patient in restraints, offer frequent toileting and food and water with any age group, but especially with your older patients. Now, treatment settings for older adults can vary. You have hospital-based care. This can be partial hospitalization for those people that do not need continuous 24-hour psychiatric care, and this will bridge inpatient care and community living. Inpatient care involves treating any acute symptoms or providing crisis care so that they can be stabilized. There are multiple home-based services, and these services can provide recreation and social interactions as well as supervision in a safe environment. You have daycare programs, a day center for health and wellness as well as social and educational activities, and this can give relief to the caregiver. You have home health care, which assists with transitioning back to home environment and aids with their ADLs, housekeeping, meal preparation, and managing their medication. When managing medications, encourage a safe storage area and keeping of all medications, and teach them not to keep their medicines in unlabeled containers. You have community support services. These are specialized case management such as Meals on Wheels and transportation. And you also have respite care. This is designed to help with caregiver burnout and provide a break for several days. It can be provided in a facility or possibly in a home. Residential care, you have assisted living. This is for individuals who need little to no assistance with ADLs. Assisted living provides care for chronic illnesses, including mental illness, but it's usually not covered by insurance. And then you have your SNFs, your skilled nursing facilities. These are most long-term care facilities, and they do not provide specialized psychiatric care. Now remember, there are many myths about aging, and this can have a negative impact on the quality of care they receive. Older adults are more prone to be victims of a crime, so listen to them and assist. And remember that learning never ends, even when we're older. So Mr. Nixon is being admitted to a short-term care facility because his wife, who had been his only caretaker, has recently died. His son, who lives about 250 miles away, has been staying with him for the past 4 weeks, but has to go home now to go back to work. Mr. Nixon has COPD and has trouble getting around because he gets short of breath. He is still grieving, of course, but his son shares that he feels his dad has been depressed over his health off and on as well. You will be doing an intake assessment with Mr. Nixon. You are preparing to interview Mr. Nixon. What are some techniques the nurse could use to help the patient feel more comfortable? Well, 1, you can conduct your interview in a private area. Introduce yourself and ask the patient what they prefer to be called. Using a first name is rarely appropriate unless you've been invited to do so. Establish rapport and put the patient at ease by sitting or standing at the same level as your patient. Ensure that lighting is adequate and the noise level is low, in recognition of the fact that hearing and vision may be impaired. Use touch, with permission, to convey warmth, while at the same time respecting the patient's comfort level with personal touch. Summarize your interaction, invite feedback and questions, and thank the patient for giving their time and their information. Now, Mr. Nixon, who has difficulty walking because of shortness of breath secondary to COPD, says, "Every day is a struggle when you get old. No one cares about old people. Select the best response." B, it sounds like you're having a difficult time. Tell me about it. This is an open therapeutic communication technique.